Morning. I'll be talking to you about preventing limb length discrepancy in total hip replacement. So why do you want to prevent limb length discrepancy? The reason it alters your hip biomechanics, leading to a dysfunctional gait and causes low back pain, which drastically impacts functional outcomes. It's also the leading cause of patient dissatisfaction after a hip replacement and is the most common reason for litigation why orthopedic surgeons are sued after surgery. Rarely, it may also require revision to correct the discrepancy. So to prevent limb length discrepancy, the procedure starts with obtaining appropriate radiographs, calculating the preoperative LLD and templating with a focus on achieving the length, making use of intraoperative landmarks, and all these together help you achieve optimal length post-operatively. So through this talk, I'll be walking you through our protocol of how we obtain X-rays and template with a focus on achieving optimal length. So when we obtain X-rays, we attach a 100 millimeter, that is a 10 centimeter rod, cylindrical rod, which is taped at the level of the greater trochanter of the patient's hip. And this serves as a magnification marker, which helps us to calibrate our X-rays to the true size. Then you need to identify varus and valgus hips, as this also affects your limb length discrepancy. Ideally, you should calculate the neck shaft angle on almost every hip that you do. And an easier way is also to eyeball a line which passes through the tip of the greater trochanter, which should pass through the center of the femoral head in a hip with a normal neck shaft angle. If it is a varus hip, you will notice that this line which passes through the tip of the greater trochanter will pass above the center of the femoral head. And if it is a valgus hip, it usually passes below the center of the femoral head. So the problem in coxa valga is that there is low offset and more length, and these hips are at risk of shortening. Whereas on the other hand, when you have a coxa vara hip, these hips have a higher femoral offset and a shorter neck length, and these hips are at risk of lengthening. So what you need to bear in mind is to have appropriate stem options available for a case of coxa vara. Most implant systems have a standard hip stem which is of 135 degrees, but when you have a coxa vara hip, you need to have a stem with 125 or 127 degrees available. So here is a case example where you can see on the opposite side that it was a varus hip, and the line passing through the tip of the GT also goes above the center of the femoral head. However, on the operated side, a stem with a neck shaft angle of 135 degrees was used, and then you can see that this has caused some lengthening in the hip which was operated upon. So what you need to understand is that the neck length, the neck shaft angle, and the offset are all interrelated with one another. So in the schematic representation, if you notice that the blue circle is the femoral head and the red lines are the neck and the shaft of the femur, then you will realize that the triangle that is formed denotes the offset. That is, A is the horizontal offset and B is the neck length. But what you're realistically looking at is C, which is the vertical limb length, which is why any increase in the neck length B will also increase your horizontal offset and your vertical limb length. And similarly, any decrease in the neck shaft angle will affect the offset and the neck length again. Then you need to calculate the limb length discrepancy preoperatively. While there are many techniques to do this, the one we prefer is by drawing a line between the teardrops of both the sides. And this red line serves as your horizontal pelvic reference line. From this horizontal pelvic reference line, you draw a perpendicular line to the center of the lesser trochanter and compare this distance on both the sides. The difference between both the sides will tell you the discrepancy that is there, and you need to account that into your pre-op plan. Again, there are two types of limb length discrepancy, that is true and apparent. True is usually supratrochanteric shortening, which is due to an intra-articular cause, like you may see in AVN or osteoarthritis, and this supratrochanteric shortening needs to be corrected in your total hip replacement. On the other hand, when you have an apparent limb length discrepancy, it may be due to pelvic obliquity, spinal disease, or adduction and abduction contractures, and you need not correct this apparent limb length discrepancy. Again, also look out for pelvic obliquity. When you have a pelvic obliquity, that is again due to two reasons. It may be a flexible pelvic obliquity or a fixed pelvic obliquity. If it is a flexible pelvic obliquity, it corrects in the seated position, which you will commonly see is due to adduction or abduction deformities. This pelvic obliquity will resolve in 6 months or even a year after surgery, and the important message here is that you should not prescribe any shoe raise post-operatively to correct a flexible pelvic obliquity. On the other hand, a fixed pelvic obliquity does not correct in the seated position and is usually due to a spinal disease. A fixed pelvic obliquity will not resolve after surgery, and you must counsel the patient accordingly. So the final step before the surgery that we template is the neck shaft angle and the vertical offset. As I mentioned, the neck shaft angle is routinely around 135, but in a coxa vara or a coxa valga hip, you need to modify your stem choice accordingly. Then we calculate the vertical offset. That is a line drawn from the center of the femoral head to the center of the lesser trochanter. So this vertical offset is what we usually use to plan the level of our neck osteotomy. So in this case example, if you notice that the distance from the center of the femoral head to the center of the lesser trochanter is say 60 millimeters, and the stem that we use as a standard stem that we use is the Corail stem, which has a neck length of 39 millimeters. So let's assume as a round figure it is 40 millimeters. So to plan the level of our osteotomy, we'll subtract the neck length of the stem from the native vertical offset. So that gives us, in this case, the number of 20 millimeters, and that is the level at which we will plan our neck osteotomy, because the remaining 40 millimeters will come from the neck length of the stem. Intraoperatively, you can cross-check this again, where after you dislocate the head, you mark the center of the lesser trochanter, mark the center of the femoral head, and measure this distance again. So again, if it is 60 millimeters, you mark a point at 20 millimeters on the neck, and that is where you perform your femoral neck osteotomy. Then, after you've broached the femur and your trial stem is in place, cross-check this measurement again, and you select your head trial accordingly. So if your desired vertical offset length was 60 millimeters, and you get about 56 or 57, then you can opt for a +5 head. Whereas if you've overshot that distance, you can select a minus head. Again, what you need to remember is that a +5 head does not give you 5 millimeters of true lengthening. It corresponds to about 3.75 millimeters, because as we noted that the neck length is B, but lengthening is C, which is the vertical limb length, and that will correspond to about 3.75 millimeters for a +5 head. Again, after you put in your final stem, cross-check this distance again and then select your final head size. Once you've done the trial reduction, palpate the sacrum and make sure that the pelvis is fairly horizontal and not drooping forwards or backwards. And then you align both the feet with the medial malleoli overlapping each other and palpate the level of the knees anteriorly, which tells you whether there is any lengthening or shortening after your trial reduction. The important message here again is that you need to do this before you start your surgery, so it gives you a good starting point, and not do it directly after your trial reduction is in place. So when you do it before the incision, you know what it was to begin with, and you can use that as a reference point after your trial reduction to gauge your limb length. Other techniques that we also use are the Ranawat technique and the use of calipers. In the Ranawat technique, what you essentially do is you put in a Steinmann pin in the infracotyloid groove, which is the posterior inferior lip of the acetabulum. Just posterior to that is where you insert the Steinmann pin, and you mark the corresponding point on the greater trochanter before dislocating the hip. Then after you perform your trial reduction, you recheck this mark against the Steinmann pin, and that gives you a fairly accurate estimation of lengthening or shortening, because this Steinmann pin is extremely close to the center of rotation of the hip. Again, there are commercially available calipers that you can use, which not only help you with the limb length, but also give you a good estimate of the offset restoration. The shuck test and the drop kick test have also been described. However, these are very fallacious and unreliable because of the effect of anesthesia and tissue laxity, and the strength of traction that you or I may pull are again different. So these are not very accurate to use for practical purposes. Thus, to conclude, you need to have a meticulous pre-op plan and template your hip accordingly, identify varus and valgus hips, identify the cause of pelvic obliquity and limb length discrepancy preoperatively. Remember that stability is more important. So sometimes you do need to lengthen your hip to achieve sometimes you do need to lengthen your hip to achieve appropriate stability. So that should not come at a cost of achieving appropriate limb length. And 0.5 to 1 centimeter of limb length discrepancy is well tolerated. If it is more than 2 centimeters, it may rarely require treatment. Thank you.